All right. Good evening, everyone, and thank you for joining us tonight. We're very excited about this presentation. I just want to make a couple quick announcements before we get started. First, I'm Lisa Clausel. For anyone who doesn't know, I'm the Community Relationship Manager at the Lupus Society of Illinois. Tonight, we will be recording this presentation, so I do ask that you keep yourself muted, and we're going to keep the videos off just so we have that for the recording. And then we will open up for Q&A at the end. So if you do have questions throughout the presentation, please chat them to either me or to the group, and then we will spend the last about 10 minutes going over questions. I did want to, about today's presentation, this event is an educational and informational purposes only and serves to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendation. This information should not substitute or replace expert medical care. Before making any changes to your medical care, consult your qualified healthcare professional familiar with your medical condition and health status. Once again, this is going to be recorded and we'll probably have it uploaded early next week and available on our website and our YouTube channel. I did want to just bring up a couple upcoming events. Next week, I will be doing a sit-down talk with LaShawn Garola talking about heart awareness and lupus and kind of a journey that she's been on. And then, why isn't my presentation not moving forward? I'm not sure why my slides aren't moving forward. I will show, oh, there we go. So you can register for that. It will be on Zoom, so you can see the meeting and ID and passcode there as well. I will show this again at the end, but it is on our website, so register. We'll send you the reminder next week, but we hope you join us on Tuesday night. The LSI Associate Board is hosting a soccer game at Soldier Field for World Lupus Day. We are selling tickets for $36 and hoping to have a big crowd come out, cheer on the fire, and mingle with other lupus warriors and their friends and family. Like always, we'll host our annual walks. We're still working on nailing down the dates and locations, so we'll hopefully have that in the next couple weeks. If anyone is interested in joining a committee to help plan the walks, please let me know. Our 2025 Chicago Marathon team is currently full, but we are taking open runners. If anyone would like to join as an open runner, please contact the office and we'd be happy to give you all the information. If you are interested in volunteering or an internship opportunity, please reach out to us as well. And we just want to thank everyone for joining. These events are made possible by your donations, so we would really appreciate any support that you can. All right, I am going to introduce Doctor. So I'm going to put my glasses on for this one. Sorry, everyone. Dr. Vakharia is a dermatologist and pharmacist at Northwestern Medicine. He is part of the dermatology team at Northwestern with a focus on lupus and other autoimmune disease. Given his pharmacy background, he is also a principal investigator for clinical trials for cutaneous lupus. I do want to say that about a year ago, Dr. Vakharia reached out to LSI and wanted to get involved, and he works close with Dr. Blanco, who a lot of you have met at other presentations, and he has spoken to several of our support groups and met some members, and we've only heard wonderful things about your presentation, so we're really excited to have you, so welcome. And I hope everyone learned something, and again, put those questions in the chat, and I'll hop back on in a little bit to go over those. So take it away. Thank you so much.
Thank you, of course, and thank you for the introduction. Thank you for allowing me to talk today on cutaneous lupus. I'll go ahead and share my screen. Can you see this okay?
Yes, I can.
Okay, perfect. All right, well, so like Lisa was saying, I work at Northwestern. I'm a dermatologist, and we'll today's talk will be focused on cutaneous lupus, which is one of the interesting aspects of lupus. I am an active investigator in some clinical trials in the setting of cutaneous lupus. So I do want to mention that. And we'll talk about that a little bit later. And like Lisa mentioned, I do see primarily autoimmune diseases, so lupus, dermatomyositis, scleroderma, and then kind of the goal of why I got interested in these disease states, especially lupus, is because there's really a need for better treatments, but also safe treatments as well, and trying to help work with other clinicians and other institutions to help develop these. So first, let's talk a little bit about, why does lupus happen? We're not 100% sure if there's one specific thing that happens, but we do know that there are a lot of factors that can contribute to lupus forming. These include genetic factors, so if there's a family history, environmental factors, so depending on where you live, immune factors, and all of these factors can then lead to your immune system becoming more activated. And that can lead to the development of certain substances in your body that are pro-inflammatory or pro-autoimmune that then go on to cause damage in organs of the body. And these organs can include the kidney. So you may have heard of lupus nephritis. Patients with lupus can also have issues with the brain or the heart, like pericarditis, for example. But you can also get issues with the skin. And you can see there in that image, and I'll kind of use my laser pointer here. Um, this is kind of the very top layer of the skin. This is the kind of the middle layer, and this is kind of more where we have like our fat and muscle. Okay. So the skin is definitely affected and can be affected by lupus, as we've seen. And don't worry about the acronyms or abbreviations, but basically these are different types of lupus. And you can see, different types of lupus of the skin. And you can see that even within the skin, different parts of the skin, the top layer, the bottom layers where the fat is, the middle layers where our hair glands are, our sweat glands are, um, different layers of the skin can also be affected. And that's kind of interesting that that happens, and that leads to different findings on the skin, as we'll talk about. So because of that, there are different types of lupus of the skin, or what we call cutaneous lupus. The most common types are acute cutaneous lupus, subacute cutaneous lupus, and then chronic. So acute is something that means it happens very quickly and it goes away kind of quickly. Chronic means it happens more gradually and it goes away very, very slowly. So we'll kind of talk about each of those subtypes, but there are a variety of other types as well. Okay. Now, when we talk about acute cutaneous lupus, many people may know this more as like a butterfly type rash. So after being out in the sun, patients may get red burning, even maybe some flaky skin, kind of on the cheeks and maybe even involving the bridge of the nose as well. And this is called acute cutaneous lupus. It happens very quickly after sun exposure, and it can go away on the quicker side as well. Patients who have this are more likely than other types of skin lupus to have SLE or systemic lupus. So we know that if a patient comes in with this type of cutaneous lupus, that we need to check to make sure that they don't have systemic lupus. There's another type of cutaneous lupus called subacute. So kind of a little bit slower to develop, but usually also sun exposed or sun induced. You can see here in this photo, this lady here, the majority of her lupus of the skin is in a V-neck distribution on the chest, so where she would get sun exposure, the outer arms where people get sun exposure. And it can look like a couple things. It can look almost like ringworm of the skin. You've got these round rings here. Or it can even look like psoriasis. So some people initially have been thought to have psoriasis for a long time, but actually end up being diagnosed with lupus of the skin. And then one of the more common types of lupus of the skin is called discoid lupus. Up to This is probably the most common type of cutaneous lupus. And what happens is these usually start as small red spots that kind of grow a little bit and they become coin shaped, so discoid. They become coin shaped. They can be purple, and often they're very flaky or scaly. And we generally see them from the neck upward. So the head and neck area is a very common area, including the ears, the bowl of the ear, the scalp. And this can actually cause hair loss. And that's one of the reasons why it's so problematic is that if it is not under control, it can spread and lead to more areas of hair loss that is actually potentially irreversible. So we call this discoid lupus, and this is a type of lupus that we are very aggressive with because we don't want it to cause any scarring and we don't want it to cause any permanent disfiguration or hair loss. There's another type of lupus called tumid lupus, which almost looks like hives a little bit. And so people might think they have hives or even maybe even ringworm again, but it's very swollen. It's almost like if you were to be bitten by a ring of bites. That's how swollen and juicy it can get. But this is actually a type of lupus, and it can go mistaken by a lot of people. But with the right clues and right suspicion and the right training, this could be prudently diagnosed as cutaneous lupus. There's another type of cutaneous lupus called lupus panniculitis. And this is where lupus, as I mentioned, it can affect different layers of the skin. Actually, the fat, so kind of a little bit deeper in the skin, starts to get affected. What ends up happening is as a result, those areas become kind of dimpled in and they kind of crater in a little bit. So you can see here this lady has this area that kind of dips in, um, and this lady here has it on her cheeks. And so this can be also very disfiguring, and it can be this specific type of lupus of the skin can actually be very hard to treat. So again, we treat this very early. We treat this aggressively because we don't want it to cause some of those irreversible changes and have it spread to other parts of the body as well. On the contrary to a type of lupus that dimples in, this is a type of lupus that actually sticks out. We call it hypertrophic. They kind of look like warts in to some people, and they kind of jut out from the skin. They're very thick. They're very scaly. They can get misdiagnosed as a lot of things, psoriasis, warts, but actually it's a type of lupus. And there are some clinical clues that we look for as a dermatologist with our microscope, with our specific tools that we use in the clinic, training and experience, and also just the areas of involvement that can tell us that this might be more lupus. Now, what's interesting and concerning about this type of lupus is that if these areas are not treated, patients can actually develop skin cancer within these areas. So it's very important that we diagnose it and treat it. This is a type of lupus called chilblain lupus. And basically, um, sorry, give me just a second. This is a type of lupus where um, the lupus affects primarily the fingers. So um, it kind of is worse in the wintertime or in the cold when we start to get a little bit less blood supply to the fingers. But it can be very painful. And some people may actually have this mistaken as Raynaud's, which we'll talk about, which is a different phenomenon that can happen in lupus. But this is actually different. You can actually feel something on your fingers. This is another type of lupus where patients can actually get blisters on their skin in areas that have been exposed to the sun. And this is actually a very significant type of lupus because it can tell us a lot about how their underlying lupus is doing because it may not be doing well if they're developing this type of lupus of the skin. Now, there are other skin findings seen in lupus. So what I just went through are different types of lupus of the skin, different types of cutaneous lupus. But patients who have SLE or systemic lupus, they can also have other things happening on their skin. One of which is called vasculitis. And this is when the blood vessels in the body, and oftentimes the legs, are very inflamed. And they kind of develop this bruising type look on the legs or other areas. And some people may think, oh, it's just some bruising on the legs, or oh, I just got bit by some bites. But actually, it's a sign that the blood vessels are very angry. And this does require prompt treatment, actually. Something that a lot of patients with lupus have is Raynaud's. Raynaud's is what happens when a lot of people go out in the cold. Their fingers turn white as the blood flow to the fingers gets kind of constricted or restricted. And then it turns blue as the blood vessels kind of react to that. And then it turns red again as blood flows back to the fingers. And that whole process can be very painful. It can be so bad to the point that it actually causes ulcers on the fingers that require treatment. And the development of those ulcers on the fingers is not a great sign and usually necessitates treatment. There are a lot of patients who are on specific treatments for Raynaud's, and we'll talk about that. But this is a very common finding we see in patients with lupus. One of the last skin findings we'll talk about is what we call calcinosis. So patients can develop little deposits of calcium on their skin, usually the fingers or other bony areas like the elbows or the knees. And this can be very painful, as you can imagine, if you were to have this on the pad of your finger. And it can really affect the quality of life. You know, just think of how often you use your fingers when you're typing on your phone or typing on a keyboard. So this is something that is hard to treat and very painful for patients, but things that we have ways to try to manage. Now I've mentioned this before, so I apologize if you've heard this before, but a lot of patients with lupus, as they know, lupus doesn't often just come by itself. A lot of times it likes to bring a friend with it. And so what I mean by that is patients with lupus often may have other autoimmune diseases. Commonly, they may have rheumatoid arthritis. Some patients may have scleroderma or muscle disease, what we call myositis, or Sjogren's disease as well. And so it's very important when we see patients who come to us for lupus, we also do a very good job of checking everywhere, both the blood work and their skin, especially their skin, to see if there are any findings that could suggest some other autoimmune conditions that has been missed outside of just their lupus. And we call those overlap syndromes. Now, when we talk about treatment, the goal of treatment is to clear or reduce the number of skin lesions, prevent new skin lesions, and limit any long-term consequences. So scarring, disfigurement, um, dystrophy, change of how the skin looks or feels. Now, there are a variety of topical treatments that we use for lupus, and some of you may at some point have been given this for lupus, or maybe even something else like eczema or psoriasis. Now, steroid creams we've been using for a long, long time, and they work very well. Hydrocortisone and triamcinolone are some common ones people have used. But we were also trying to use medications that are non-steroidal. A lot of patients with lupus have been given lots of steroids in their lifetime, whether it's topically or by mouth, and that may not be good for them in the long run, especially on their skin, where steroid use can cause thinning of the skin, it can cause discoloration. So when possible, we try to use non-steroidal medications. There's a new one we're going to talk about a little bit later called tapinarof. And there's another one called ruxolitinib or Opzelura. You might have seen commercials for it. It's used for vitiligo, it's used for eczema. And this is kind of actually just hot off the press. There was a study that was done looking at this cream for patients who had that coin-shaped type of lupus, what we call discoid lupus. They used it in 10 patients, and what they found is that this graph is kind of showing a downward slope or a downward trend in basically how bad or the severity of their lupus. So their lupus over those 8 to 12 weeks is getting better when they used this ruxolitinib cream. So we know that this cream can potentially be helpful as a non-steroidal option for patients who have cutaneous lupus. And this was actually just published it'll be being released in March of 2025. Now, there are a lot of other medications we use for lupus of the skin, and many of these you are probably familiar with. Hydroxychloroquine or Plaquenil, mycophenolate, methotrexate. So some patients who have cutaneous lupus, where it's affecting a lot of skin or it's causing those types of changes that we want to stop, we start them on systemic medications. There are some patients who we even have to start on stronger systemic medications. And some of you may have heard of these, rituximab or IVIG or intravenous immunoglobulin. Um, and There are even for cutaneous lupus, even newer treatments that we use primarily at academic medical institutions. There's one in particular called anifrolumab, which we're going to talk about as well, that we've been using for cutaneous lupus very recently and which has worked very well. Now, obviously, one of the big things with lupus of the skin and lupus in general is photoprotection. So we tell all our patients to wear sunscreen, to wear a nice, fashionable, broad-brimmed hat when you're going out by the pool or going out in the sun. We love to give our patients samples of sunscreens for them to try. There are some that are have color in it or are tinted because there are different shades that we try to match with different patients to help them find the best sunscreen that they like. There are a couple other treatments as well that are kind of specific to those other findings we talked about. So if you remember, we talked about calcinosis, which is when patients can get little buildup of calcium in certain areas. And there's a medication called sodium thiosulfate. We can inject this into the area, or we can apply it topically as a cream that can help shrink that calcium. As you can see here, I'll bring my laser pointer out. This patient had some calcium here that then decreased over time with treatment. This is another patient who had this spot here that decreased with injections. This patient here decreased with injections over time. There are some other treatments that we use as well, oral medications that we can use to help fight the calcium buildup. Um, so we do have a few treatment options in our inventory. Now, Raynaud's, as many of you know, non-pharmacologic measures are probably the most important. So keeping your hands warm at all time, wearing gloves. You know, I know a lot of people think that the winter time is the worst time to have Raynaud's, but I have a lot of patients who actually in the summertime their Raynaud's is more active because everywhere they go, the AC is blasting. They go to the grocery store, the AC is blasting. They go to the doctor's office, the AC is blasting. And so I tell them to always take gloves with you, even in the winter time, wearing some people we tell to wear or recommend even heated jackets, those heat packs that you can break in an emergency when your hands are really cold. And as many of you may know or may be on, we also use medications to help kind of open up those blood vessels so that they can help promote good blood flow to the fingers and the toes. Okay. That can include medications like amlodipine or sildenafil, um, medications that you may have heard of, and they work very well, and they're generally relatively safe. Now, the one thing I tell all patients is if you've got a finger that is blue, or finger or toe that is blue or purple, and it's not changing back to its normal color, you should let your doctor know immediately, because that could be a bad sign that that blood vessel may not open up again. And we've got to get you into urgent care, or seeking urgent care at a hospital potentially, to get that blood vessel opened up. Okay. Now, one other thing that we do also in dermatology that's unique is Botox. And how Botox works for Raynaud's is we actually inject Botox into certain areas of the skin where our nerves kind of collect, in the fingers. And what happens is in Raynaud's, the nerves are the main culprit that cause the blood vessels to kind of shrink and constrict. And if we use Botox, we can kind of prevent the nerves from doing that. And as a result, the blood vessels in the fingers don't constrict, and they stay kind of nice and open. This is a patient who had pretty bad Raynaud's with kind of a big ulcer here on this finger, who started getting Botox shots every few weeks, and you can see in just less than a couple months' time that finger is starting to look a lot better. So we do this pretty frequently in our clinic for patients who have Raynaud's, who, especially patients who, those oral medications may not be working, or they can't take those oral medications because of side effects or other reasons. So it's a very nice tool for us to have at our disposal that we use quite frequently. This is kind of a heat map of patients, and that was published, of showing that they kind of looked at the blood supply and the temperature of the toes before doing Botox. You can see it's kind of cold by that blue color in the toes, and then kind of returns to a little warmer color in the toes. Same thing here in the fingers. You can see all across these three patients, they all had kind of bluish discoloration to their fingers, and even up to their hands, you can see. And then kind of a return of good temperature to the fingers, a short time period after doing Botox. So we do know that it helps, and we do know that it can help promote blood flow to the fingers. Now we'll kind of talk a little bit more about lupus. Lupus overall, we are seeing more people being diagnosed with lupus, and that's just generally across the board. Systemic lupus in particular, more people are being diagnosed. And as a result, we know that those two often go hand in hand. Patients with systemic lupus can have cutaneous lupus. Up to 50 to 60% of patients can have cutaneous lupus. So as a result, we're also seeing more patients with cutaneous lupus. As a result, we've seen research in cutaneous lupus essentially double from 2015 to 2022. And this was kind of collected at the halfway point of 2023, but essentially kind of doubling over the last decade. And that's great. It's great to get more research done in this area. And as a result, that research has kind of led to the development of potential new treatments that might be helpful. And we're kind of going to talk about some of those. I said that we would come back to some of those. Anifrolumab was one of those medications I talked about that's kind of being prescribed more so at academic medical sites. And a quick little background is that in lupus, there is a specific substance called type 1 interferons that are known to be bad, known to kind of promote the development of lupus. So these type 1 interferons are no good. Anifrolumab kind of blocks that. It blocks the effects of that substance. So that's a good thing. This medication is actually already approved for the treatment of SLE, or systemic lupus. There were a lot of trials where they studied this medications for systemic lupus, and it worked very well. But what they also found in these trials is that it was beneficial for lupus of the skin. This graph here, this pink and blue line show how many people in that trial, about 70%ish, had a significant improvement in their lupus of the skin. So about 70-ish percent, anywhere from 60 to 75%, had a significant improvement in the lupus of their skin when they were getting the medication for their systemic lupus. So that led people to be like, all right, well, let's try it for cutaneous lupus. We know it works in these other studies. So since then, there are lots of reports of anifrolumab being used just for cutaneous lupus, so patients who don't even have systemic lupus. And this was a patient here who had pretty significant lupus on her chest, and you can see essentially cleared after starting this medication. This is a patient here who had pretty significant lupus of the scalp with associated hair loss. And you can see still active a little bit. There's still some redness there, but better than before. This is a patient who also had some hair loss and some lupus of the scalp that now has seen a significant improvement. This is another patient you can see with significant improvement on the chest area. And these are a couple more patients as well. So this is the chest. You can see how that improved over time. This is the arm. You can see how that improved over time. And some other patients here as well with the hands, the knees, the chest, the fingers, the face that have shown pretty remarkable improvement in their lupus of the skin. So what does that mean for us? Well, um, we'll talk about that in just a couple more minutes, but this anifrolumab medication is something that we have been using now for cutaneous lupus for some of our patients here that we see at Northwestern. Um, we it sometimes can be tough to get covered by insurance, but we we do our best to continue to fight, and we've even gone so far as having peer-to-peers with the medical directors of insurance companies to try to get the medication approved, because we think if it's in the best interest of our patients, we are going to try to get it in their hands. This is another medication, daxdilimab. We're not going to spend too much time talking about it, but it works very similarly. Basically, it decreases the production of those type 1 interferons, which we talked about was bad. Okay. And this is a medication that will eventually be approved for cutaneous lupus. And very similarly, about 70 to 75% of patients had improvement in their lupus of their skin. But we won't talk too much about this medication. The last medication we're going to talk about is a medication called deucravacitinib. Now, you guys might have heard of this if you've seen commercials for a medication called Sotyktu. That's the same medication. It's actually already approved to treat psoriasis. So this medication already is approved, and that's probably why you've seen commercials for it. But what they found was that it also works very well at fighting lupus. There was a clinical trial done looking at this medication and treating patients with systemic lupus, and it did very well, actually. What they found, very similarly, was that lupus of the skin improved. And these are some patients who had lupus on their skin. This lady had it on her face. This patient had it on the knees and the arms, and you can see how it did after being on this medication. So there have been a few more case reports of this medication being used. And you can see here in this table over here, a good proportion of the patients had almost complete skin clearance or very significant skin clearance on this medication. So this is another medication we have used off-label. So we're using it not for psoriasis, but we're using it for lupus of the skin. This is medication that we've used because it is shown to be very helpful. And then lastly, I just wanted to share some news about some of the work that we've done at Northwestern. This is One at the bottom right, that's Dr. Jay Choi. He's one of my colleagues. He kind of spends more time in the lab, so he does a little bit more of basic research, working in a lab. And what he found was there is a specific substance, a specific thing that is actually very important in lupus. And it was never really known, this thing was never really known before. And their lab actually found this out. It received a lot of national attention, him and his lab, um, and potentially being very helpful as a new target for lupus. And essentially, what this target is, it's called the aryl hydrocarbon receptor. Essentially, what it does is in lupus, there are increased levels of this right here, which is bad, and low levels of this, which are good. This thing right here, the aryl hydrocarbon receptor, decreases the bad cells and increases the good cells. So if we can stimulate the aryl hydrocarbon receptor, we can decrease the bad cells even more and promote the good cells even more. And thus that could help fight lupus. So we'll talk about this and how this what this means for you guys and for patients in just a minute as well. And that kind of gets to the next point. I know as Lisa had mentioned, we do a good amount of clinical research and clinical trials here at Northwestern. We have a very active site here. And one of the trials that we're doing is, and I mentioned this before, is anifrolumab. Now, anifrolumab, that medication I had mentioned before, that currently comes as an IV medication. So patients, when we administer it, they have to go to what we call an infusion center, and they sit there for a couple hours and they get an IV medication, and they do that once a month. However, what they're trying to do is see if that medication also works as an injection. So you don't have to go to an infusion center, you can just do an injection once a week at home. And we're lucky enough that we actually get to be a site for this clinical trial. So we have patients who we are putting in, or who are interested in this clinical trial for the injectable version of anifrolumab for the treatment of cutaneous lupus. We'll kind of jump over the next couple things. The next trial that we're doing that's very important is a trial looking at tapinarof. Now, this is actually just a topical medication. And this is actually, when I was talking about that aryl hydrocarbon receptor, this actually works via that pathway. So this is actually stimulating the aryl hydrocarbon receptor, which, as we mentioned, can be very beneficial for lupus. And this is a clinical trial we're doing where patients apply this cream to their areas of lupus once a day for 4 months. And basically, at the beginning of the trial and the end of the trial, we're going to see how their lupus looks. Patients get reimbursed, I think, or would get compensated up to $400 for completion of the trial. And this is something we're very excited about because it's also, as I mentioned, important that it's not a steroidal medication, which is also very good as well. I also wanted to kind of just share a little bit of what we do in clinic. And, if any of you ever see me or have seen me in our lupus clinic, this is one of the things that we kind of grade and score patients with their lupus severity. So how severe, how mild is their lupus? This is one of the forms that we use. And I'll kind of break it down a little bit more. Basically, we go through each anatomic area of the body, from the scalp all the way down to the feet. And then we grade how red the lupus is. We grade how flaky or scaly it is. We grade how discolored it is, how scarred it is, and we give each one a number. And every visit, when we see patients, we do this. So then we can see, is the lupus actually improving or not? Sometimes we look at things and we're like, you know what, this looks a little bit better than last time. Not exactly sure. And, we can take photos, which we do, but these objective measurements are very helpful. And so having patients and being able to objectively tell them, well, hey, your lupus scores have gone down by 25%, by 50%. That when we have that conversation with patients, that's actually quite meaningful to them as well. And this is the bottom half of that scoring system. We look inside the mouth, we look at the scalp, we look to see if they've developed any hair loss, we look to see if they have any scarring of the scalp, and we give them a total score for their activity, how active is their lupus, and then how much damage or how much scarring and discoloration have they had on their skin. And this is something that we collect and collate each visit where patients come. This is another tool that we also use and we collect each visit where we grade a representative lesion on the skin, and we use these certain criteria to give it a score of either clear, almost clear, mild, moderate, or severe. And so that can also be helpful when telling patients, hey, last time most of your skin lesions were severe, today they're mild. And so we can use those objective measurements, or even vice versa, if it's going the other direction, and we think that necessitates starting different treatment. And then lastly, why is this so important? Why is cutaneous lupus or skin signs so important? Well, one, visibility. It's one of the first things that we see, that people see, and it's important that we help treat that so patients can have a good quality of life and they can be comfortable doing their daily activities as well. We also know that all patients with skin lupus, they need to be monitored because they could potentially develop systemic lupus. Some patients can develop cutaneous lupus and then develop systemic lupus. Some patients may develop skin lupus only, and they may never develop systemic lupus. We also know that the skin is a window into the body. And if the skin is flaring and the skin is not doing good, there's a good chance that means the systemic lupus is also not doing good as well. And then as mentioned, some of these types of lupus of the skin can lead to chronic irreversible skin changes. So how do we as dermatologists play a role? Well, one, diagnosing patients. As I mentioned, some of those types of lupus, they're not easy to always diagnose and catch. There's different types and they can be misdiagnosed as different things. And so having a dermatologist who's trained in autoimmune diseases and has seen a lot of lupus patients can be very helpful, especially with those subtle skin findings that we talked about as well. The earlier we detect it, the better. The earlier we can start treatment, we can prevent some of those chronic irreversible changes. We also know a lot about topical treatments and systemic treatments in our dermatology training, and we can help manage the skin manifestations. We provide input to our rheumatology colleagues, our nephrology colleagues, our pulmonary colleagues, cardiology colleagues, in terms of how we think the skin is best treated with different topicals and systemics. And so it's very helpful for us to be a part of that team. As I mentioned, we're often at the forefront of new treatments, both systemically and topically, for the skin features of lupus. So patients who, come to a academic site such as ours and who see patients like us or see providers, academic dermatologists, may know about some of these newer topical treatments or newer systemic medications that might be good options for them or people they know. And then lastly, collaborative care. As I mentioned, we work very closely with our rheumatologist here and all other types of specialties, and we talk very frequently. I just was talking to Dr. Blanco earlier today about a couple people, and we talk very routinely about people and patients, and we make decisions kind of collaboratively and as a group. And so it's great to have that togetherness and have multiple minds kind of coming together. And so that's one of the things that I really enjoy being a part of as well. So I just want to thank you all for allowing me to present. I'll definitely feel free to post any questions in the chat group. I do want to thank some of the rheumatologists who I work with closely, especially Dr. Blanco, Dr. Mayhew as well. If any of you have seen her, also Mary and Lisa and the LSI, you guys have been great to work with over the past year. And this is a photo from one of the Lupus Spoons meetings that Mari had hosted. I want to say that was last fall. And we had kind of done kind of an inpatient hangout or in-person hangout, and I think it was the 5th year anniversary of their support group. So that was us celebrating there. Um, Feel free to, I also posted my email address there. If you have any questions, if you'd like to come see us in our lupus clinic, um, send us an email. We can help coordinate things. I chat via email with a lot of people, and don't hesitate to reach out.
All right. Well, thank you so much. That was very informative. I will tell you, I hadn't heard of several of those different conditions. I think we hear a lot of discoid lupus, and that's kind of the only one that's like super familiar, I think, with in the media type thing. So it was very interesting. I know I learned a lot. Some questions are coming in. A lot, everyone's saying thank you, very informative. I guess I'm just kind of thinking of, people who maybe don't go to Northwestern, and maybe live in the suburbs or a different state. And would you say their rheumatologist would send them to a dermatologist? I know you're lucky to work at a big campus of a lot
Mhm.
of great doctors and research, but if you don't go to a
Yeah,
doctor that
yeah.
has that, how does that work?
That's a great question. So you're absolutely correct. Even for people who live in Illinois and or Chicago areas, and in the downtown area, we have access to so many academic sites here, but that's not always the case out in the suburbs or in different states and different cities. So generally, what I tell people is, if you live in a different state or different city, generally your first best bet is to look for the closest academic center. So, for example, some of our patients who live in Indiana, Indiana University. Um, in general, though, that's not always an option for a lot of patients. Um, and what usually ends up happening is generally through word of mouth, the rheumatologists that people see generally have worked with and have good experience with the dermatologist who sees those types of conditions, who sees more of the complex dermatology, even if they're out in various parts of the state or its different cities. So definitely asking your rheumatologist if they know of any dermatologists that they could have you meet with. And a lot of times, patients may not really have much skin features, but even just chatting with the dermatologist to see if there's anything fruitful that could come of that discussion can be very helpful. Um, those are probably the most common ways that we tell patients to help find some access to dermatology.
Would you recommend somebody with SLE to see a dermatologist regularly as well?
Yeah, that's a great question. I would say it really depends. I would say uh, there's and what I usually tell patients is patients if you have systemic lupus and at some point you've had something on your skin. It might be fruitful to see a dermatologist, and they could tell you that, this is not lupus. We do not need to see you regularly. Um, or they might say, yes, this is a part of your lupus, and we might want to see you regularly. In addition to that, even asking your rheumatologist, hey, do I have any skin findings of lupus? Um, because a lot of times what may end up happening is, in certain parts of the country or certain parts of the state where there's not great access to care, different providers, whether it's a rheumatologist, whether it's even a primary care doctor, they might be managing some skin findings, and that's just kind of what they've done historically. But if they know that their patient's interested in meeting with the dermatologist, I'm sure they would love and be more than happy to refer someone to see a dermatologist.
Okay. I know a lot of the facts are, majority of SLE is in women, childbearing age. Do you see with cutaneous lupus that's still the same kind of base of who has it, or are you seeing more men with it, or
It's a great
children, or
Yeah, that's a great question. I would say still predominantly female, um, and I would say still primarily of childbearing age. However, I do believe there is data that shows that there is a higher percentage of um, male patients who have cutaneous lupus than male patients who have systemic lupus. So we do know that cutaneous lupus can affect men maybe a little bit more than systemic lupus affects men. And so that's very interesting to see because as a result, our patient demographics of who we see vary from, different ethnicities, different genders, different age groups. I see adolescent patients with cutaneous lupus, and I see patients in their 60s and 70s who've had lupus, and some who even developed it for their first time in 60s and 70s. So I'd say the majority are within that childbearing female age, but definitely with cutaneous lupus, it's maybe a little bit more diverse.
okay. What's the most exciting research you're seeing on the horizon right now?
Yeah, that's a great question. I think the most exciting research is one. Um, in general, a lot, and I think a lot of people might attest to that, is lupus has often gone a long time before being diagnosed, whether it's systemic lupus, cutaneous lupus, and, a lot of bad things had to happen before it was realized that a patient had lupus. And I think we are improving so much on diagnosis that a lot of people are getting diagnosed earlier, which is great. But we still don't necessarily have, very specific lupus targeted treatments. A lot of the medications that we use, like Plaquenil or Cellcept, these are kind of just broad either immune suppressing or, like Plaquenil, just kind of anti-inflammatory medications that work well for lupus, but we don't really know exactly, they're not very targeted, I guess. And because of, we're catching patients earlier with lupus, we're able to start them on treatments earlier. Um, but we also know that they can benefit from, they may not need to be on such a strong medication like Plaquenil or Cellcept. And, as we're doing these clinical trials and we're finding treatments that are more just specific to lupus, like anifrolumab, that these medications may be safer in the long run, and they can be more effective. So I think for me, the most groundbreaking and exciting thing is that I think we are starting to develop and we even get in our hands some lupus specific treatments that are safe and very effective.
Okay, here is a question I'm going to try to pronounce everything correctly for you. Could Impredigo have been
Mhm.
misdiagnosed as skin lupus, such as bullous
Yeah.
lupus, although it's less clustered?
Yeah, that's a great question. It's possible. They can present very similarly. Impetigo might have more of like a crusty, infected look, and that usually goes away with antibiotics. Bullous lupus usually would require like lupus-specific treatment, but they can look very similar.
Here is it's not a question, but more of a statement, and maybe you have some information on this. She said she's been to several dermatologists and none of them have been this thorough. They provide a steroid cream and send you on their way.
Yeah, we have heard that before. It's tough, and that's kind of when you'd ask that first question about for patients who don't have access to academic sites, that's kind of why it's also challenging because I think for better or worse, I think a lot of us who, are interested in these disease states and work at these academic sites, this kind of is our passion, and we spend a lot of time in research and seeing it and more up to date on it. It is kind of hard to know, if you're just meeting with a regular dermatologist out in the community, what kind of training they have with lupus and whether that's something that's a disease state or not. That's where I think, at least word of mouth can be more helpful if you are in that situation where, maybe your rheumatologist has seen someone, knows a dermatologist who's well versed, or maybe your friends who have lupus have seen someone. Um, but it's kind of a tough thing to balance because we do know that the type of care one may get at an academic center may be different. So I understand and empathize with that situation as well.
Um, Here's another question. I've been on Plaquenil since 2006, and I've been told that the cause of dark spots on my skin might be due to the long-term use of Plaquenil. Please share information on whether the Plaquenil might be causing this latest condition or if you know of any other possible causes.
Yeah, that's a great question. So yeah, Plaquenil, as I mentioned, kind of potentially a stronger medication, but it can cause what we call hyperpigmentation or discoloration. Without seeing the dark spots, it's kind of hard to say if that's the cause of it or not. But Plaquenil can cause discoloration, but there are other things that can also cause dark spots. Cutaneous lupus of the skin can present as dark spots. Sun damage and sunspots can also present as dark spots. So there are a lot of things that can present as dark spots of the skin. So it's hard to answer that specific question, but you are correct in that plaquenil can cause discoloration.
Okay, and then I know we need to wrap up on time, so just wanted to um ask you, how do people, I know you put your email there, how do people find out about studies in general? Like if they're like, should
Yes.
I join a study? And should they, a two-part question is, should they talk to their regular like rheumatologist and say, hey, I saw this study at Northwestern, can I join? Or how does
Yeah,
that all work?
that's a great question. So actually on our Northwestern page, I apologize, I didn't put a link in there, but if you type in dermatology, Northwestern dermatology clinical trials, there will be a whole slew of of clinical trials that we're doing in the department. Um, and like I said, these two specific ones in regards to lupus, I don't know exactly if they're, I'll have to double check to make sure they're on that up and running on that website. But yes, you can definitely ask your rheumatologist. They should be aware of anifrolumab. They may not be aware of that topical cream as much. But you can also ask your dermatologist if you see a dermatologist, or ask your rheumatologist if they can refer you to a dermatologist, or depending on your insurance plan, if you can make an appointment with a specialist without a referral. You can also talk to them about the clinical trial as well to see if it's the right fit for you. In dermatology, we're aware of the other medications patients are on. We see notes from other specialties, and like I said, we generally chat with the other providers. We don't generally make decisions unilaterally, so we kind of make decisions collaboratively.
Okay, well, great. Thank you again so much. Um, oh, someone said, Lisa, can I send out, oh, can you send out the link?
I'll see if I can post it real quick. Let me
Okay,
see if I can.
yeah. Oh, there it is. All right. Well, again, thank you, everyone. We really appreciate everyone's time. I just do want to just remind everyone that on Tuesday, I will be doing another talk with LaShawn Garola. We hope you guys can join us then. That more information is on our website to register for that, but it's a Zoom link and we're going to talk about heart and lupus and how that all works. And hopefully you'll learn something there as well. We do have some other upcoming events. So stay tuned. Check out our website often as we will be posting more about our walks and upcoming events. In the future, and we do have that LSI Associate Board soccer game on May 10th. So again, I'd like to thank everyone for hopping on. Thank you, Dr. for joining us as well. There was some really great information, and I hope that some people contact you because there's some really good things on the horizon. So Dr. Vakharia, thank you, and everyone have a great evening.
Thank you all. Have a good night.
All right. Bye.